We'll hear next more about these diseases and deaths of despair from our next speaker, John Auerbach, President and CEO of Trust for America's Health, or TIFA, a prevention-oriented, Washington-based policy, advocacy, and research organization. John has held senior public health positions at the CDC and as both Boston's and Massachusetts State Health Commissioner. At each level, his work involves efforts to promote health and prevent suicide and other leading causes of death. Under his leadership, TIFA's Pain in the Nation work has drawn critical attention to deaths of despair in America and facilitated dialogue on how to advance evidence-based strategies to promote wellness. We're pleased that John is with us today to share this work. John?
Oh, thank you, Catherine. I'm going to focus on one particular aspect of mental health trends, and that's the increase in suicides. Suicide prevention is one of several health topics that are priorities for us at Trust for America's Health, and we work with Congress and the administration as well as with states and local government and the general public on this issue. And our work is generously supported by the Wellbeing Trust, and many of the materials and lessons I'm about to share reflect their commitment and their expertise. As we've already noted, there's been a striking increase in terms of the number of suicides in the last decade. And this chart just shows it with the dark blue line. We've gone from about 29,000 to 47,000 suicides annually in the last 20 years. And over the same period of time, as shown by this chart, we've seen a rapid increase in the number of deaths from alcohol and from drugs. And these three causes of death are not coincidental. When we consider the root causes of each, we see notable similarities. And this suggests that we consider them in relationship to each other, especially when we emphasize prevention. Therefore, while I'm going to focus on suicide, I'll return to the topic of the common upstream factors associated with the three causes of death. In addressing suicides, we also believe that a comprehensive approach is needed, one that starts with a detailed look at the data, at studies that looks at the evidence about risk factors and the ways of reducing those risk factors, and that looks at the role of multiple sectors, including healthcare and public health, but also education, business, housing, and public safety, just to name a few, and thinks about the entire spectrum of need, from infancy and childhood through adulthood, and from primary prevention to emergency intervention. Our series of efforts under the title Pain in the Nation does reflect that approach. And you'll hear me talking a good deal about policy. With regard to suicide specifically, this chart indicates that all demographic populations have been affected and are seeing increases. The increases you see in this slide are those that took place over a 10-year period from 2008 to 2017. But while all are affected, some have had the largest increases, such as those under 34 years of age, Black and Latino populations, those in rural areas, and women. Of course, it's worth noting that some of the populations have higher overall rates that these increases were built upon, such as white men, white populations in general, and men. And these rates still are higher, even though for those populations, even though this chart may show them having a lower increase. Looking at the data by subpopulations actually is important for a number of reasons. One is the importance of promoting equity, and while all may be affected by the risks associated with suicide, other forms of mental health, there are important differences that exist with regard to access to high-quality care. Low-income people and people of color in general face elevated challenges. And it's important to focus on reducing some of the underlying causes of trauma that may contribute to suicidal risk, and these may be more likely to be seen in certain subpopulations. These underlying causes, including such things as adverse childhood experiences, which are more likely to affect populations with more limited economic resources or populations facing systemic discrimination, are noteworthy if we are to pay attention to the promotion of equity in our work and make sure that all people have a fair and just opportunity for wellness. The next slide also just shows that those differences really extend to states. This chart, actually the chart that you're seeing there, combines the risks associated with alcohol, drug, and suicide deaths. And you can see that there are significant differences. The states with the highest suicide rates are Montana, Wyoming, and Alaska. That would suggest that there are particular challenges in what are sometimes referred to as frontier states that may have major geographic barriers to care and specific types of risk factors, including access to guns, that require specific approaches to address the conditions they face. When a suicide attempt is made, it's usually the tip of the iceberg with regard to risk, and our comprehensive approach attempts to think about all the ways that intervention could have been possible. This pyramid reflects that, with the top section reflecting those who actually die as a result of suicide, and the bottom reflecting a much broader section of those who are at elevated risk because they've endured some form of trauma or adverse childhood experiences. And in between are escalating conditions and diagnoses that reflect greater and greater risk of suicide. This conceptual image is a reminder that we can intervene long before someone is suicidal by working at those lower stages of the pyramid. A complementary pyramid reflects the various stages of risk and suggests when and how we should best intervene with, for example, attention to changing the conditions in people's lives at the bottom of the pyramid, and higher levels of the pyramid assume that the adverse experiences may have already occurred, and they focus more on screening and building resiliency. But a focus on all levels of the pyramid is part of that comprehensive approach I was mentioning. We in public health really think about upstream, and here's just some of the categories that we think about when we try to work not just within the healthcare system, but also at the community level and at the family level. Now, I'm not going to mention much about the what are the optimal approaches within clinical settings, because you've already heard of those. I will just mention in this regard that a policy that really matters a lot is access to comprehensive health insurance, and the Affordable Care Act provided that for an additional 20 million people who, as a result, may have easier access to mental health services, including those that can help to prevent suicide. And that was built as well on the work that was done in the Mental Health Parity and Addiction Equity Act of 2008. And this notion of parity, I think, as a policy issue is important for us to keep our eye on, because even though that act was passed in 2008, there still are challenges with regard to parity and coverage. And great work is being done by Patrick Kennedy and the Kennedy Forum to pay attention to the efforts that we still need to focus on policy level to ensure that parity becomes a reality in the provision of high-quality mental health services. Again, we covered the issue of integration, so I'm just going to skip over this slide. I will mention that an excellent set of services or a model for how to address issues related to suicide have been developed in the Zero Suicide Framework at the Zero Suicide Institute at EDC. I won't go into it here other than to say that it provides an excellent model, and that people interested should Google that at Zero Suicide and EDC to receive the materials related to it. I do want to instead focus on more of the upstream, more of the social determinants for consideration. And I'd start by saying that it's when looking at suicides, it's important to think about the methods of suicides, because that suggests some of what needs to occur both in the clinical setting but also at the policy level in addressing some of those social conditions. This chart, for example, shows the leading methods of suicide deaths, and you can see that the light blue line related to suicide deaths from firearms is by far the highest and has been increasing steadily over the last decade and longer. The red line refers to suffocation and hanging, and that too has been increasing rapidly over the last 10 years. So paying attention to those causes of the methods that are used in suicides is important for both clinical and policy reasons. Clinically, this is an example of why it can be important to pay attention to those. A study was done which indicated that when clinicians screen and counsel people who may have mental health diagnoses or a suicidal ideation, they can reduce the risk by focusing on ways of making both guns less accessible or potentially dangerous medications less accessible. And as you can see from the chart, counseling had a significant impact in terms of reported behavior. This slide provides, I think, some surprising information about suicide, in that it indicates that when, according to a recent analysis by the Centers for Disease Control, that more than half of people who die by suicide didn't have a known mental health condition prior to their diagnosis. CDC found that this was particularly true for men, and that those men were most likely to die from firearms. This slide focuses a little more deeply on, well, what were the precipitating circumstances in those deaths where there wasn't a prior mental health diagnosis. And they found that there was a range of circumstances that precipitated the suicide, and those included things like relationship problems. About 42% of the suicides in this category had those risk factors, or financial or housing-related problems, adding to about 20%. And as a reminder that suicide and drugs and alcohol misuse are related, about 28% had a substance abuse problem. When I was the Massachusetts Public Health Commissioner, we actually found that among those who had the highest rates of suicide were those returning from armed services abroad. And we also found that those recently released from correctional facilities had significant high-risk behaviors that place them at risk as well. And that suggests that in major transitions from stressful situations, special attention should be paid to those populations. To address the range of conditions that CDC found among those who died of suicide, a number of responses are needed. And certainly there should be screening for those who may be going through those situations, and reference and linkage to appropriate services, as we've heard. But other approaches could address the underlying causes themselves, such as developing policies that promote housing stability, economic opportunities, and strong family supports, as well as criminal justice reform. And there are a number of materials that have been developed for people who want to work at that upstream level. This slide illustrates one of those. It is a new report called Promoting Health and Cost Control in States, or FACTS, and it provides 13 evidence-based state policies, many of which will lessen the social determinants associated with suicide or with substance abuse disorders, including the ones that I was just mentioning that CDC identified as part of the circumstances prior to a suicide. They do such things as lessening housing and economic crises and combat some racial and other form of discrimination. Other evidence-based approaches that are worth noting include the Centers for Disease Control's Health Impact in 5 Years, or High Five initiative, and the de Beaumont Foundation's City Health Initiative. Each of these can be Googled for their research tools and technical support, and of course we would be helpful to contact anyone and let them know of how to reach those materials. So finally, I would summarize by saying that when thinking about suicide and truly thinking about mental health in general, a multi-sector approach is best. And those sectors certainly include clinical care and public health, but they also do extend to other sectors like education, the criminal justice system, housing, economic opportunities. The blue chart you see on this slide is from the Centers for Disease Control and their excellent package on preventing suicide, and they illustrate that there is a role indeed for every sector and for each individual in terms of considering how to lessen the likelihood of suicide or a negative outcome, how to help in terms of getting people services and screened and connected to services, but also how to think about the ways that we can have an impact on the conditions in people's lives so that we promote health and well-being and reduce the likelihood that people will end up needing many of the mental health services that we've been discussing as essential for those with symptoms. So in conclusion, I just want to say please check these various sources for additional information. Our website is one site that has a comprehensive set of resources available. So Catherine, thank you very much, and back to you.